Okay, sir. Thank you very much, sir. I think for want of time, we will go on to the next topic. Is it okay, sir, Dr. Thirumurugan, sir?
Sir, please proceed, sir.
Yeah, so the next topic is the development surveillance in office practice. Actually, because of the time constraint that we have in our office clinic, sometimes we don't take a proper developmental history and we tend to miss a lot of development disorders and fail to guide these parents. So now we have Dr. Srinivas Ragavan to enlighten us about these problems that we face in the office and how to do a developmental screening in the office practice. Thank you, sir. Over to you, Dr. Srinivasan, sir.
Thank you, sir. Are you able to hear me?
Yes, sir. Of
Yes,
course.
yes, sir. And can you see my slides?
Just it's going to come out, sir. Now, yeah, now it's there, sir. It's there.
Yes, sir. Thank you, sir, for the kind introduction. I'd like to start my talk by thanking my mentors, my teachers, and I dedicate this talk to all the lovely children and their families who motivate me to learn further to help them. Today's talk is essentially going to be a bird's eye view of early childhood development and what is the role of primary care pediatrician with respect to early childhood development. So I'm going to focus this talk pertaining to these three P's. One, what is our role in picking up early? What is our role in providing appropriate and correct guidance? And what is our role in promoting a positive environment at home? So, and this format is going to be like a story. And this talk is divided into 6 acts, and I'm going to convey 6 key messages through some patient stories with you. So as sir rightly said during introduction, whenever we talk about developmental surveillance in a busy office, the reaction is immediately skepticism. So the first act or the first section is going to be on demystifying developmental surveillance in busy office, how a simple developmental surveillance can be done, which can pick up most of the common developmental disorders. A simple solution should be the family should not be coming to our clinic for extra visits. So there should be no burden on the family. So well child visits, 3 well child visits can be tied up along with vaccination at 9 months, 18 months and 24 to 30 months. And by doing this simple developmental surveillance, most of the common developmental disorders can be picked up. How do we start the session? Provide milestone checklist to all the parents along with vaccination cards. Let them fill up this milestone checklist before they visit you. And while they come to you, you review the milestone checklist. And if you notice some red flags, then do a focused history and examination and proceed. So I'm going to explain this using 3 common scenarios. And what do you need for this developmental surveillance? You just need some toys, some picture books and a notebook and head circumference measuring tape, something to check hearing, a rattle or a bell. That is all you need. You don't need any complicated equipments to do the simple developmental surveillance. Most of these that I've shown here, I've picked up from my daughter's toy box. The first story, this is the story of 9-month-old Amuda who's brought for vaccination. Mother says, sir, innum kolanda ukkarave matengra. This child is born at term and she was of good birth weight and there are no abnormalities in the neonatal period. The simple evaluation that can be done during the 9 months vaccine visit must be focused on. This is the first well child visit. The focus of first well child visit would be picking up vision abnormalities, hearing abnormalities and motor impairments. What are some things that we can do? Shake a rattle behind the child. So shake a rattle out of view of the child and see if the child is able to localize sound. And move a bright toy from side to side and see if the child is tracking. And see if the child is reaching out for the toy. And while reaching out, is there any definite hand preference? A child who has good vision will definitely be interested in the toy and he will try to reach out for it. And a child with good fine motor eye-hand coordination will be able to reach it with both hands. And if there are no weakness, there should be no hand preference for a child at this age. And then you can check for object permanence by covering the same toy with a kerchief and see if the child is able to uncover the toy and finding out the hidden toy. And another simple measure that can be done is we all put the child to the couch to examine the child. While you're doing this, as you take the child out from the couch, do this simple maneuver of pulling the child to sit and making the child stand and allowing to weight back. What are the things that can be picked up? If the child has head lag and if the child is having persistent head lag, then you can suspect neuromuscular weakness. In a child with cerebral palsy that is causing motor delay, you can pick up bilateral scissoring of legs. And if a child with hemiplegia, you can pick up abnormal weight bearing. On one toe, on one leg, the child will be standing on toe. On other leg, the child will be weight bearing well. And to close the session, you can offer the child a raisin or a sugar crystal or kalkandu kudukalam, and see how the child is picking it out of your hand, and check pincer during this maneuver. So just by doing these simple measures and just by observing the child while doing these things, you will be able to pick up common developmental problems in this age group. So when we apply that to Amuda, you find Amuda is turning to rattle and trying to reach out for toys, saying vision and hearing is fine. When you pull the child to sit and make stand, you find there is no head lag, but she's not sitting alone. And as you make the child weight bear, you notice that on the right leg, she's standing on her toes. When you check for object permanence, she tries to remove the cloth to see the toy, but persistently she's using the left hand. And there is obvious left hand preference when she tries to pick up the toy, and she has not got a pincer grasp yet. So what has it helped us identify? There is motor needs for child, and there is probable right-sided weakness which warrants further evaluation. Remember, this is only a surveillance which points towards further direction and is not a full-fledged developmental assessment. So going on to story two. Story two is 18-month-old Surya who has come for vaccination. And as he enters the room, you find that the mother has snatched away the phone from his hand and he started crying. And mother says, "Yappo pathal in the phone da venungran sir. Innum pesa matengran, edu venunalu he's crying. He's only crying for everything to indicate his need." And on examination, neurologically, you find there are no concerns with the child. He has not had any perinatal risk factors. Now, the focus of 18 months vaccine visit would be to pick up milder motor impairments. And again, the key thing that you should do in this visit is pick up autism in a child who was presented with speech delay. So language milestones and social milestones should be watched for during this visit. What simple things you can do as the child is walking into your room, or make the child walk inside your room and observe gait. Watch for any hemiplegia or diplegia. Ask the child to point to some body parts. By this age, child should be able to point to at least 5 body parts. And look at the eye contact when you approach the child with the toy. See, for example, you have a hand puppet here. As you wave to the child and make close to the child, see if the child is making eye contact with you and smiling at you. Then give a picture book to the child and watch what the child is doing. As you take history from the mother, the child will be seeing through the picture book. A typically developing child of this age should be able to share some of her known pictures with the mother by pointing to the mother. Look, I found something here. And observe the child as the child is sitting on the mother's lap. Typically developing children of this age should have a good social referencing. What is that? In any unknown situation, they'll take cues from the people around to understand and get a grasp of the situation. So children who have come to you for the first time, or children who have come to you a clinic and who are very anxious, they'll be wary of you. They'll be looking back at your face and the parent's face as you talk to the child or as you interact with the mother. So this can be easily observed. And that you can give a child a toy with the key and see what the child is doing. Please see this video. As you can see, the child is enjoying the toy as he's playing. He is expressing by smiling. And when he receives the toy, immediately he turns back to the mother and says, "Look, I've got this toy." Now he's trying to play the toy he's not able to do. Observe what he's going to do. What does he do? His facial reaction changes and he asks for help. So after a toy with the key finishes playing, the child should be able to share this enjoyment and child should be able to ask help. That is what typically developing children of this age should do. So applying to Surya, what do we notice? Surya is able to walk well. There are no gait problems. He enjoys the picture book, but does not share enjoyment with the mother by pointing to the pictures and other things. As soon as he gets inside the room, he gets down from the mother and walks away, and is more interested in the things in the room than the people in the room. And as the mother calls him, "Surya, inge paru, tala inge kami," like that when she calls, there is no response to name call. He does not point to body parts here. And you also observe that he has very poor eye contact when you approach him with the doll. He tries to snatch the toy, but he's not seeking help with you. So what you have identified, a language delay by history and definite social needs by simple evaluation. That warrants further evaluation for autism in this child. Now going to the next story of Meera. Meera has come for vaccination and mother says, "Innu teliva pesa matengra sir. Innu oru vaarthaiya pesra. Innu urine motion போறது அவளுக்கு சொல்ல தெரியல. She's not indicating her toilet needs and I find it very difficult to control. எங்கே போனாலும் ஒரே துருன்னு இருக்கிறா." That is mother's complaint. And again, neurologically no concerns and there are no risk factors in this child by history. The focus of 24 to 30 months well child visit would be picking up specific language impairments, a language delay, and a child with early intellectual disability. So what you can see, as the child is entering into your room, watch the child. Does the child greet you? Give a high five to the child, see if the child is responding. Have some toy blocks of different colors in your room. See what the child is doing with it. A child should be able to build a tower of 5 to 6 blocks and name few colors. With the same blocks, you can ask some colors. Have some toys with some pretend play equipments like a cup and spoon. See if the child is able to engage in a good pretend play, and ask some simple questions to the child. "Un per enna saaptinga, dosa pudikuma?" Like that, some simple questions can be asked. Elicit some answers. Simple yes and no a child should be able to do, or at least the child should be able to nod understanding your question by this stage. And give a paper and crayon and observe the child's grasp. Watch how the child is able to hold the crayon in hand and make strokes. By 2 to 3 years, a child should be able to have a digital grasp, meaning they should be able to hold it in the palm with the fingers and control the movement of the pen and crayon. This is a typical digital grasp of a 2-year-old, a 2-year completed child. But if you observe that the child is holding by the entire palm and is only making strokes or poking at the paper, that means the grasp hasn't developed as much as expected. So applying all this simple evaluation to Meera, what do we pick up? The child does not answer. The child does not answer. The child, you give blocks, the child is only trying to throw them. The child is having only a cause and effect play, but does not have a constructive play. And child, when you give a crayon and a pen, she holds it with a cylindrical grasp and only pokes at the paper. She does not have strokes, but she's able to give a flying kiss. She's able to wave bye-bye. And when you give a doll, she only tries to throw the doll or try to bang the doll. She's not having pretend play yet. So what have we picked up? Definitely Meera has needs in language and social and probably cognitive domains, and this child has to be evaluated further. So the key message one that I would like to say is, where there is a will, there is a way. Manam irundal margam undu. Developmental surveillance combined with vaccine visits in the form of at least 3 well child visits at 9 months, 18 months and 24 to 30 months can pick up most common developmental disorders in busy office even. So where edume pannalana kuda, at least these 3 well child visits will help in monitoring development of all children. So going to the second act, where we are going to discuss some common etiologies we are likely to see in our practice. The common needs that children present to us in the early childhood are for motor needs, language needs, and vision needs. The common causes of motor delay are brain injury in the form of prematurity, intrauterine growth restriction, HIE, neonatal jaundice and hypoglycemia, and nutritional deficiencies presenting as motor delay or as a part of global developmental delay. And language delay can be secondary to hearing loss, autism spectrum disorder, or understimulating environment. We'll talk about it later. And vision impairment also children can present. What is one important message that I want to convey is, not all delayed development is CP. So how do you approach a child with any developmental delay? See which domain is affected predominantly and then approach further. And just like any other thing in clinical medicine, history and examination provide vital clues to etiology and determine workup in up to 70% of children with developmental delay. So meticulousness is the key. Meticulousness in history taking and examination. So let us see the story of Inba, who's a 1-year-old child who's brought with complaints of not walking and not crawling. And parents have noticed that child engages in hand flapping and body rocking stereotypies. So outside child was referred as autism history-wise, birth weight of 1.8 kg, child has had a neonatal hypoglycemia with seizures. On examination, the tone is normal. When you see the child in the clinic, you see that the child responds to mother's voice by cooing. As the child is holding the child and talking to her, the child hugs her and child is responding to her tickle very well. That tells you that the social interaction, at least when mother talks, she recognizes her mother and she's interacting with her. That is not against autism. So delving further, when we saw the child further, we could find out the child was having a preferential down gaze. And by the 9-month examination, when you show the toys, this child was not trying to reach for the toys. she was attentive to the sounds that rattles make, but when we give the toy to the hand, the child was trying to search for the toy and pick up, and she was not tracking. So that is how the child will search for the toy and pick up. So there are obvious vision concerns, and hence an MRI was done. An MRI showed typical hypoglycemic brain injury. If you see here, the occipital region, there is prominent gliosis and volume loss. The occipital horn of lateral ventricles are dilated. So parieto-occipital gliosis with volume loss is very typical of neonatal hypoglycemic brain injury. So one important aspect which we have to follow up is children who have had neonatal hypoglycemia, early visual stimulation is a must. Eye is the window for the world. Eye is the way how a child relates to the world and interacts with the world. It can manifest as motor delay, cognitive delay, and social delay, because child is not able to see the world, and hence it can mimic a global development delay. It can mimic autism. It can also present as learning problem. So CVI, cerebral visual insufficiency, should always be considered in a child with vision impairment. Remember, fundus examination can be normal, and hence a functional visual assessment must be done by a trained ophthalmologist. This is a story of Deepa, who's an 18-month-old who's come with complaints of not walking alone and feeding issues. எதுவுமே சாப்பிட மாட்டேங்கறா சார், பிஸ்கெட் கரைச்சு கொடுத்தா சாப்பிடுறா and தாய்ப்பால் கொடுக்கறான். That is what the mother is telling. So obvious nutritional concerns are there. On examination, she was irritable and weight was less than -2 standard deviation. Clinical examination shows a hyperpigmented skin, a pale hair, and she also had a bald tongue. What does it tell you? There is a suspicion of vitamin B12 deficiency. So rightly so, this child was investigated further. The vitamin B12 levels were very low. It was only 50 picograms per ml. The child was started on vitamin B12 therapy and nutritional advice was given. And you can see the follow-up visit. The child is smiling. She has begun interacting with the mother. Child was not walking well, started walking alone. Of course, a minimal occupational therapy also was started, and refusal of solids also had improved. And here you can notice that the hyperpigmentation also is slowly resolving. Hence, correctable causes such as this must never be missed in clinical practice. And as highlighted by Dr. Hemachand in the previous talk, this is an 11-month-old girl, Suji, who presented with complaints of not sitting, not speaking bisyllables. Short stature is there, coarse facies, umbilical hernia. This is textbook description of congenital hypothyroidism that was missed in the neonatal period. The TSH was very high and free T4 was very low, and thyroid scan showed agenesis. And 1.5-year-old Zahir was brought with complaints of not walking without support. This child had an uneventful perinatal period. He was good socially. He was talking kinship words. Neurologically, he was normal. But still, why the developmental delay? Subtle wrist widening was there, and there was no bowing in this child. So we did a vitamin D levels, which showed a very low vitamin D levels with a normal calcium. Another important aspect which we should remember is vitamin D deficiency in young infants can cause isolated motor delay, and there are publications on this as well. So the key message too is never miss the forest for the trees. Meticulous history taking and careful examination often provide vital clues. So we have to be meticulous. Causes that should not be missed at primary care level are hearing loss, vision impairment, hypothyroidism, and nutritional causes. So implementation of universal newborn hearing screening and newborn thyroid screening can be done easily. And this is the plea I would like to place before the elite audience here. Wherever feasible, please implement newborn hearing screening and newborn thyroid screening, because this will go a long way in preventing these common developmental disorders, early remediable and treatable developmental disorders. Now, coming to a scenario of speech delay. Typical language development proceeds in an orderly fashion. First, for a child to talk, the child should have an intent to communicate. Then the child will socialize with the people around with a good eye contact by drawing attention of others with a joint attention, taking cues with the people around and understanding the environment around by social referencing. Then child begins to communicate non-verbally and then verbally. Verbally, babbling with varying intonation starts, and then only language comes. So, ஒரு குழந்தை பேசல அப்படின்னு வரச்சே, first we have to understand which component is lacking in this child. Is the intent good? Is socialization better? Is non-verbal communication good? And only then the verbal component should be checked. In children with autism, there is often a problem with even the intent to communicate. They have poor intent to communicate. So, autism உள்ள குழந்தை பேசல அப்படிங்கறச்சே, what we have to understand is அவனுக்கு ஏன் பேசணும் அப்படிங்கிறதே தெரியல. That is why he does not understand what to talk. So அந்த குழந்தைக்கு போய் வெறும் ஸ்பீச் தெரப்பி கொடுக்கிறதுக்கு பதில் first we have to understand him. He has to socialize with the people around, and then only he will start talking. So let us see a video here. One of them is a typically developing infant, and another is an atypical development, another child exhibiting atypical development. So let us see what happens here. They are around 1 year of age. So when the name is called out, you can see the infant on the left side of your screen immediately responds by turning and smiling. Observe the other infant. Now the infant on the left side finds an interesting toy. What does he do immediately? He shows to the people around. So such an ability to relate to the people around, such an ability to share interests with the people around, such an ability to be wary of the people around should typically be there before language develops. So that tells you clear cut that the child on the left side is typically developing, whereas the infant on the right side did not exhibit any of this, and he was only engrossed in the toy that he was seeing, and he is showing some atypical social development. He is likely to have language development, and he should be followed up for development of autism. Now, this is a story of two children who were presented at 2 years of age with speech delay. Now see the first video. The girl is playing. She's seeing the mother who is sitting in front of her, and the mother is demonstrating something to her. You can see the child is engaged in a pretend play. Yeah, mudiye illada or doll ku thala vaariட்டு இருக்கா. So that is like very high pretend play for the child. She has imagined the hair on the child and even combing it. This child is now mixing something which the mother has shown her. So she's able to imitate. As the mother points to the doll, she understands the gestures of the mother also. And intermittently, she looks at the mother and people around and she smiles at them. So what does this tell you? There is speech delay, yes, but definitely the socialization is good in this child. Now observe the second child. The same toy, a same pretend play doll is given, but what does he do? He's only trying to throw the dog. At this age, you expect him to at least try to feed the dog or hug the dog, talk with the dog or play with the dog. Now the father is trying to imitate him to have at least some functional play. Take the teapot, trying to pour tea out of it, all those. But observe what he's doing. He's only attempting to stack these cups one over other. That tells you that this child is not attempting to socialize with the people around, and he has a non-functional play, no pretend play. So that tells you that child 1 has good socialization. The speech delay is not due to autism. Whereas child 2, there are definite abnormal social development which warrants further evaluation for autism. So the key message 3 that I want to say you is the devil is in the details. In a toddler with speech delay, think of autism if you notice a poor intent to communicate. Verbal, non-verbal, both are affected. You saw in the video 2, the child did not have eye contact with the father. Whereas in the first video, the child was immediately looking at the mother and constantly looking at the people around. There is no sharing of interest. There was no warm smile on the child's face in the second video, whereas the first girl was smiling very well. And in the first video, the infant was very happy to share a toy with the person standing there. And a child who does not engage in pretend play at 2 years of age always think of autism. Moving ahead, the next act, I call it as beware. Because sometimes when we see common things in clinical medicine, we try to do pattern recognition. But in developmental pediatrics, what you have to understand is sometimes there could be a wolf in sheep's clothing. So how to identify such mimickers? Here is a story of two siblings who are referred to us as cerebral palsy. Both were 5 and 7 years of age. They had difficulty in walking. They had tightness on examination, and hence they were diagnosed as cerebral palsy. But probing the history further, these were born to third-degree consanguineous marriage. The perinatal period was uneventful. They were good weight children, and they had cried at birth. These children were well till 1.5 years of age, after which they had a minor illness, following which the motor milestones regressed. But they did not have any associated seizures, and parents say the tightness is slowly increasing with age. Now, there are definite pointers to say that this is not cerebral palsy because there is no history of risk factors, siblings affected with a similar pattern, progressive spasticity, regression after minor illness, and all this occurring in a setting of consanguinity. So rightly, inborn error of metabolism should be suspected, and these children were eventually proven to have arginase deficiency. So this has mimicked cerebral palsy in this child. Another story of a 2-year-old boy, second of twins, brought with complaints of Nikkela, and child is only crawling. He has spasticity, whereas the twin brother, who is of same age, is climbing up and down stairs. Both were delivered as preterm 32 weeks. This twin was better in weight compared to the other twin. Their neonatal period was otherwise uneventful. Again, this child was referred to as CP. They had no seizures or regression. And the pattern, if you notice, gross motor is significantly delayed. 2-year-old child performing at a 6-month level. But language, this child is speaking 2-word phrases. He's able to indicate toilet need. And as a thumb rule, language milestones are an indicator of cognition in early childhood. It is a general thumb rule because many studies have shown that language development predicts later on cognitive development. So this says that this child is cognitively able, and mother also vouches for it, saying smarter, this boy is smarter than his twin. Mother is never wrong. And she says there is an intermittent stiffness of the neck. On probing the history further, mother says, காலையில எந்திரிச்ச உடனே கொஞ்ச நேரத்துக்கு கழுத்து அப்படியே டைட்டா வச்சிருக்கான், அந்த நேரம் அவன் தவழ மாட்டேங்கிறான். After 1 or 2 hours, he starts crawling and all those. That was quite unusual. So we went ahead and did an MRI scan, and that showed MRI craniovertebral junction picked up a congenital atlantoaxial dislocation in this child. So unsuspectingly, this child was picked up to have associated craniovertebral junction problems. Neurological manifestations in an idiopathic atlantoaxial dislocation can present with progressive compression of cervicomedullary junction that can mimic progressive quadriplegia. And the progression is so slow that it will be like cerebral palsy. And atlantoaxial dislocation need not be always associated with syndromes like Morquio, achondroplasia, Downs or cleidocranial dysplasia. Idiopathic AAD also is known. So when you should suspect mimics, usually cerebral palsy will be not progressive and they should show improvement gradually. There should be a history of insult to the developing brain with a corroborating MRI. When you notice there is progressive spasticity, no corroborative history or imaging findings, bladder bowel involvement, family history, regression, unexplained multisystemic involvement, always suspect mimickers. Going to the next section, which I call as the hyperactivity conundrum. A common behavior problem of children in early childhood is hyperactivity. So here's the story of 2 kids who are referred to you as ADHD. First is Anand, who's a 3-year-old child who is brought to you with hyperactivity and speech delay.
Srinivas, 5 more minutes.
Yes, sir. He's running around the room, he's humming, he's playing with his tap, he's climbing on couch, he's not sharing interest and not seeking help. And another child, Karthik, is brought to you with dog bite. Mother says that it is very difficult to control him, sir. School avan romba pesikite irukan, mathavangala thondaravu pandran. That is what they are saying. And you notice that Karthik never lets the mother talk and continuously pulls her face to show something. He questions to you repeatedly about your computer and pictures. So this child is disturbing you, whereas Anand is not mindful of the people in the room. So that is the difference between autism spectrum disorder that can mimic ADHD and a true ADHD. Well, these are some differences. Autism usually presents in the toddler age group. These children tend to be aloof, whereas children with ADHD are usually present in the school-going age group and they disturb other people. They cannot wait for their turn. And impulsivity is the key. They are very accident prone and ADHD symptoms will persist in 2 or more settings. So not all hyperactivity is ADHD. So the key message that I want to convey is there are many pitfalls in the diagnosis of ADHD. So never rush to make a diagnosis of ADHD. Think of autism in a child with in a toddler with hyperactivity. Nutritional deficiencies like iron deficiency can manifest as hyperactivity. Permissive parenting and providing immediate gratification can present as ADHD. Cognitive impairment, hearing loss, vision impairment, all those can present as ADHD. So detailed evaluation before beginning medication is mandatory. So coming to providing appropriate guidance and explaining the suspicion, a 20-month-old Advik, who's son of doctors, your long-time follower, they come to you with speech delay. You notice that he has poor eye contact, and on the very mention of the word autism, parents get upset and they leave your room, never to be seen again. So we have encountered situations like this. So these questions play on our mind. This child has developmental delay. Should I convey it or not? But definitely it has to be conveyed because early intervention is key. Reason for not telling parents is I will lose my client, but that should never be a justification for not telling. Why do parents often disagree with us? Because we often use judgmental terms. So another key message that I want to tell you through today's talk is avoid using the term normal and abnormal. Please practice use of non-judgmental terms like atypical behaviors. There are some concerns in language. There are some needs in language. Explain what is the usual course that you should see in that age group child, and tell what differences in behavior you observe to convince the parents. And when you refer these children, always talk about some common myths. அவங்க மாமாவும் லேட்டா பேசினாரு, அதனால தான் இவன் லேட்டா பேசுறான். Normal life autism child cannot lead. All these myths have to be busted and convince the parents for early treatment, because early intervention has been proven time again to provide best result. Refer for evaluation and direct parents to good information sources. And remember, early intervention to begin need not wait for confirmation of diagnosis. You can begin intervention right away as the child awaits for further evaluation. So I'd like to conclude by saying, what is our role in promoting a positive home environment? Just 3 more minutes. This is 2-year-old Deva who's not talking yet. Perinatal period is uneventful. Other domains are age appropriate. There is no dysmorphisms. Neurologically, no concerns. Pattern is an isolated language delay. And grandmother says, sir, phone எடுத்து எல்லாமே பண்றான், என்னோட ஸ்மார்ட் போன் அவனே அன்லாக் பண்றான், அவனே வைஃபைல யூடியூப்லாம் போறான், ஆனா பேச மட்டும் மாட்டேங்கிறான். This is a very common scenario these days. So both parents working, grandparented child watching visual media for more than 6 to 8 hours a day, right recipe for an understimulating environment. So for optimal development, what we have to understand is not only intact brain structure, not only a normally functioning brain, not only a good body function, but opportunities for the child to learn and practice those skills, and motivation for the child to learn and do beyond also is necessary. If these are not provided in the home environment, it can result in developmental delay. So a stimulating environment must support child's health and development. Quality family time and meeting emotional needs of the child must be very important. So I want us all to think, all these technological advances of faster air travel, telecommunication revolution, were all aimed at bringing humans together. But has it achieved that? The same technology is now pulling people apart. See here, none of them are even looking at the other person on faces. The old time travel used to be like this. We used to know the next person. We used to know something about their family. But these days, we are so near, but so far. Many things has changed for the kids of today. So working parents, nuclear family, and expensive gifts, and time that we spend with the child has gotten lesser. The psychological and emotional well-being of a child has taken a backseat. So time and again, we have to convince the parents that this is not spending time together. This does not mean spending time together. The best toy a child can have is you, the parents, and the best gift you can give your child is your time. So stimulating home environment is very essential for a child to develop. For infants and toddlers, avoid screen viewing as much as possible, provide interactive times, allow child to interact with others. For a school-going child, eat together, have tech-free times, and have a regulated media use. The key message I want to convey is an elephant in the room is obviously there, which is the screen devices, and it's high time we acted, and the change begins with us. So I conclude by giving these take-home messages. Early childhood development can be easily surveyed by us in our own office setting, and we have an important role in picking up early just by doing the 3 well child visits, by providing correct guidance, explaining the diagnosis and prompting early referral, and promoting positive home environment for all our children that we follow. And I hope that I have convinced you through this talk that screening for development in our office or OPD is imperative, is simple and doable. It always seems impossible until it's done. Definitely you can do this, and I'm sure you'll agree with me. Thank you. Thank you for your patience.
Thank you, Dr. Srinivasan. It was a wonderful lecture, and we were all really convinced. And all your pictures were very lovely, and you have given